Great. So good morning, everyone. As I mentioned, my name is Dr. Anna Minta, and I'm a medical epidemiologist on the Vaccine-Preventable Diseases Surveillance and Risk Assessment team within India, both as the team lead. So I'm very happy that you have joined the course, and I believe that we will all learn from each other as we think about ways to improve the surveillance system in our individual contexts. So to get us started, today I will be giving you a brief overview of the global strategy on comprehensive VPD surveillance. So before we begin though, I want to take us back to basics and remind ourselves, what is public health surveillance? And just a reminder that it is the ongoing systematic identification, collection, collation, analysis, and interpretation of disease occurrence and public health event data to take timely and robust action. It includes the timely dissemination of resulting information for effective and appropriate action and is essential for planning, implementation, and evaluation of public health practice. So specifically for VPD surveillance, it's vitally important for its potential to inform policy and monitor immunization programs, including vaccine introduction, coverage, and potential use for outbreak response. VPD surveillance is also able to detect changes in the epidemiology of VPDs over time due to vaccine use and other preventive measures. The objectives of a surveillance system should dictate its design rather than vice versa. And there's a phrase that says you only find what you are looking for, which I think describes surveillance very well. Next slide, please. VPD surveillance is an integral part of the Immunization Agenda 2030, which I know most of you are familiar with. IA 2030 proposes a strategic framework, and VPD surveillance is anchored in it through two strategic priorities. Strategic Priority 1.3, which is focused on building and strengthening comprehensive VPD surveillance as a component of the national public health surveillance system supported by strong, reliable laboratory networks. And Strategic Priority 5.1, which is focused on timely detection of and response to outbreaks. In both of these strategic priorities, VPD surveillance informs decisions and actions. So these are the two indicators that we are striving to improve over this decade. Next slide, please. The current VPD surveillance system is fragmented. Currently, we have national case-based surveillance for polio, measles, and neonatal tetanus in most countries. In some countries, we may also have sentinel case-based surveillance for one or more of a variety of diseases. For both types of disease-specific surveillance systems, there is investigation of all cases within a defined catchment area, laboratory confirmation, except for certain diseases like tetanus, and collection of individual level data, which should be used regularly for immunization program management. And this is what you see at the top left of the slide. On the top right, you can see that in parallel, we also have national notifiable disease reporting from health facilities, and in some cases, outbreak or event-based surveillance to capture reports from the community and media. These are general systems that detect a number of diseases. In these settings, detective VPD outbreaks may be investigated, but there's limited lab confirmation and reporting of only aggregate data, which is of limited use for decision-making by immunization programs. At the bottom, you see that the polio program currently supports much of the surveillance infrastructure in many countries, especially lab networks, surveillance officers, and field investigations. And it's important to recognize the risk of losing these resources as part of the polio transition. And then at the bottom right, you can see other challenges. So beyond this challenge, we can see that we have fragmented or parallel VPD surveillance systems. Most of the data are not being fit for use. Very few diseases have robust surveillance, and we have a weak laboratory capacity for some, particularly bacterial diseases. Next slide. So what is comprehensive VPD surveillance? We can define it at the top, you'll see, as the country, regional, and global systems that are required to meet the minimal WHO recommended standards for surveillance for a set of priority VPDs, with integration of surveillance functions across other diseases where possible. To describe more, we can say that comprehensive surveillance in the first blue bar will include more VPDs based on country priorities, and that for most diseases, this will include collection of individual level data and laboratory confirmation. In the green, we can see that the design of a comprehensive surveillance system could include a mix of nationwide case-based aggregate and sentinel surveillance based on specific surveillance objectives, which again should drive the design of the system rather than the other way around. And then in gray, you can see that the strategy to achieve this would include integration and adaptation of existing systems where possible, and common VPD surveillance support functions and funding. In orange, you can see that greater emphasis would be placed on the use of VPD surveillance data for routine program monitoring and visualizing data to facilitate understanding. Comprehensive VPD surveillance would be emphasized as an essential tool for EPI program decision-making and response. Next slide. This slide summarizes the components of comprehensive VPD surveillance in another way. So just to drive home the point, at minimum, the comprehensive VPD surveillance would include all of the VPDs that have a global surveillance mandate, such as elimination agendas, all of the VPDs with international health regulation targeted diseases, and then other regional and country priorities as indicated. They would meet the minimal WHO recommended surveillance requirements for each VPD, provide consistent reporting of surveillance data, even in the absence of cases, also known as zero reporting, ensure representative and complete detection of diseases among intended populations, reliably confirm disease by laboratory testing, and collect data relevant for decision-making in an efficient and timely manner. Next slide. So there's a lot going on in this slide, so I'll go through it step by step. This is to help us better visualize how we could build comprehensive VPD surveillance. So we start with the various surveillance system platforms in a country. As I mentioned, there are different types of surveillance. The answer is not that we only need one type of surveillance that should cover everything, but rather that we would have integration of the support functions, which you'll see at the bottom of the slide. Governance, program management, workforce capacity, logistics and communication, laboratory, supervision, monitoring and evaluation, and coordination that underpin the different types of surveillance. Next slide. To take us back to the way that the global comprehensive VPD surveillance strategy fits into IA 2030, the four core principles are the same. So the surveillance should be people-focused. Surveillance is embedded in and supported by communities and healthcare workers and is flexible to adapt to changing needs. It is country-owned. Their surveillance activities are driven by individual country needs and sustained by countries. It's partnership-based. Surveillance is underpinned by cross-sectoral collaborations nationally and globally, and data-guided. Surveillance and lab data are accessible and fit for purpose to drive national decision-making and programmatic action and use innovative techniques. Next slide. The overall aim of the Global Comprehensive VPD Surveillance Strategy is to nurture the development of country-owned comprehensive VPD surveillance systems. The 5 main objectives are very key for you to remember. Number 1, develop a workforce that's appropriately trained in surveillance core competencies, including data analysis. Strengthen and expand public health laboratory networks. Develop sustainable, interoperable VPD surveillance information systems to support collection, analysis, sharing, and programmatic use of data. Conduct operational research and generate evidence to enhance and monitor the quality of surveillance systems and ability to adapt to new data needs, such as for new vaccines, and promote sustainable financing and increase domestic government support for core surveillance activities. Next slide. So after having read the background material that you were provided and hearing this overview, which summarized their key document, you now have the chance to proceed with the course as has been described, to see what you can do to ensure that your VPD systems are comprehensive and integrated. And in this course, you will focus on how your surveillance system can achieve the goals that I outlined from the VPD strategy for workforce, laboratory, information systems, applied research and/or sustainable financing. Next slide. So thank you and good luck with the course.
Thank you very much, Anna Minta. We now open up for questions. So Charlotte has been prompting you to prepare and share your questions. We're not using Zoom webinars, so we do not have the Q&A feature. So we'll be looking for questions in the chat. We'll answer questions until the 45-minute mark. And then at 45, we'll be actually diving into some of the best practices and lessons learned that course participants shared in their application. Charlotte, over to you. Who shall we hear from first?
We have two questions already in the chat. Reda, the first question is from Mohammed Imran Qureshi, who says, what is the difference between, I think he typed the question in the chat because he's having connectivity issues. So he asks, what is the difference between specific VPD and public health importance event surveillance?
Okay, if I understand the question correctly, for when I was discussing specific VPD, so there are so many vaccine-preventable diseases, and depending on the context, some may have a higher public health importance than others. And for those, we usually talk about the prevalence of the disease, the incidence, the ability of a vaccine that can decrease the prevalence or the incidence, and also the age groups that might be involved. So, there's so many different vaccine-preventable diseases, and there's specific types of surveillance that work best for each one, or that are recommended by the WHO surveillance standards. And then for public health importance event surveillance, that could mean, for example, the international health regulations. There are some vaccine-preventable diseases that have to be reported, no matter what, even if there's one case, or if there's an outbreak, for example, they might need to be reported. So if I understand the question correctly, there are just different importance levels that are given to vaccine-preventable diseases based on the country context, because it's not possible usually to have a perfect surveillance system for every single VPD. So you have to prioritize based on your country context. Maybe as an example, I can say in some countries where something like typhoid is not very common except in travelers, they may have a different surveillance system than a country where typhoid is endemic, for example. So hopefully that addressed the question.
Okay, thank you, Anna. So we have Fitri Meles Hagos, whose hand is raised. So I'll turn towards Fitri before we come back to the other questions that are in the chat. Fitri, over to you, and please do start by introducing yourself.
Thank you so much, Charlotte, for the opportunity. My name is Fitri Meles. I'm a stroke consultant in Malawi. And I thank Dr. Anna also for the clear presentation. Thank you. So my question is like, how is the difference between the comprehensive, IDSR and the vaccine-preventable disease surveillance? How do they work together? How they are different? Because in countries you clearly see a kind of confusion, like VBDP surveillance as a separate section, and in some maybe as a part of the IDSR. And I really want to understand how countries, they really need to work on this in collaboration, as well as, I don't know, in the difference. The other thing is with this really sustainable financing for this vaccine-preventable disease surveillance, as you mentioned, the surveillance are really running on this polio eradication, financing, most of the vaccine preventable disease surveillance. So with this ramp down of budgets for polio, how do you think countries need to finance this vaccine preventable disease surveillances? Thank you so much. I think these are the two questions I have.
Thank you. So those are very good questions, and those are also some of the things that I look forward to hearing from the different participants, because it varies a lot by country. So for example, IDSR, not every region has IDSR. Not every country uses IDSR. So it's basically integrated disease surveillance. It includes diseases that are not vaccine preventable, but that typically, I would say you want to respond to pretty urgently. So for example, in some countries, there might be a separate team, like the surveillance team, that reports into IDSR maybe every week or every month. Then there's also surveillance that's focused specifically on vaccine preventable diseases. It may or may not be the same people. They may or may not use the same reporting tools to monitor these diseases. And sometimes they may have case-based surveillance, which means, for example, you hear there's a child with fever and rash. You go and do the investigation, test them for measles and rubella. Measles first, you find out it's measles, and you report it that way. Versus in other cases, you may keep a list, like last month, there were 50 patients with a certain disease, and you don't have the specific information about every patient. So that's aggregate reporting. So there are different types of surveillance systems. IDSR fits in the group of surveillance systems. And I think the point you described is key, that it's not always the same people who are collecting the information, and they're not reported the same way. So that's actually a great question as to how to integrate these systems. They may have slightly different goals, because the goal of vaccine preventable disease surveillance, as I mentioned, is to improve the immunization program, whereas the goal of something like IDSR may be more to respond to outbreaks, for example, for diseases that may not be vaccine preventable. So the response to the outbreak may be something besides a vaccine. So basically, I can't answer your question specifically. It depends on the context, but I would really like everyone to think about that, especially if you have IDSR in your country, because there can be some integration of those core functions, and you can think about how that might work, whether it's the people who are doing the investigating, whether it's the reporting system, the information system, and also the financing, which you mentioned. That's another huge topic that varies a lot by country as well. So I don't have one specific example, but I can say, for example, if you have a surveillance officer who's going to people's houses and they hear about a case of acute flaccid paralysis, for example, and they're going to test the child to see if they have polio. Could that be the same person who also goes to the house if there's a child with fever and rash who needs to have specimens taken for measles, and the same person who does other kind of household visits, because it's the same activity, just for different diseases? So those are some of the things to think about as you go through the course. Thank you for the question.
Thank you so much, Anna, and thanks again, Fitri, for that question. There's so many questions in the chat. We have less than 5 minutes for that, but most of the questions are around resources and integration. So I'm going to ask the question that is not about that, it's about Sentinel Surveillance. So it came from Pamela says, Sentinel Surveillance is not very common in my region and country. When exactly is it required?
Okay, that's a great question. And I will at some point, if it's not in the materials, give you a link or give it to Retta and Charlotte for the WHO Vaccine Preventable Diseases Surveillance Standards, which describe when different types of surveillance are indicated. So in general, something like Sentinel Surveillance is for certain diseases where it would be cost prohibitive and not necessarily necessary to test every single person with a particular disease. One example is invasive bacterial diseases. So things like maybe meningitis, pneumococcal meningitis, or Neisseria meningitis. In these situations, there are usually only a few labs who have the capacity to take cerebrospinal fluid culture or blood culture to test a patient who comes in with fever and signs of meningitis. So from a surveillance standpoint, Sentinel surveillance is when you have a few health facilities geographically located throughout your country or region, where children or adults with certain diseases are more likely to present, and where the lab is able to do the testing or to at least take the samples and save them and then send them to another reference lab. So for example, a child who has signs of meningitis would be critically ill. They would probably go to a tertiary health facility. And hopefully that tertiary health facility will have a lab that can do the blood culture and the cerebrospinal fluid culture. They can test it there and be able to have a diagnosis. And then the reporting mechanism in that case would go from that hospital probably to district, and then maybe province and to national, and eventually to the regions, and then to headquarters. So that's what Sentinel surveillance is, just with one example. And I hope that answered your question. And like I said, I will make sure you have the link to the surveillance standards so you can read when you have time about the different types of surveillance and which VPDs are needed for which type of surveillance.
Thanks, Anna. Just one quick question before we continue. From Hanan Khalil, I'm taking the second question. She asked, is zero reporting still considered important when we have case-based reporting?
Okay, that's a great question. So yes, zero reporting is very important. I can just give you an example. At headquarters, we receive the surveillance data from the regions, of course, which they've taken from you all at the country level. And sometimes we may have a disease and then it's just blank for the number of cases. So when I look at that, I don't know, does that mean there were 0 cases? Does that mean the person forgot to fill in the number? Or what does it mean? I don't know. So if there is a 0 there, then I know for sure that the surveillance was done and there were no cases that were found. So yeah, zero reporting is extremely important, whether it's case-based or aggregate reporting.